Morning, everyone. Uh, Respected chairpersons, esteemed audience. I would like to thank Dr. Khanna and the committee for giving me this opportunity. Who wants to see Madhubala, Rekha, Hema Malini when you have Deepika Padukone's and Priyanka Chopra's here? This talk may be an antique talk, and if it is a bit too didactic for some, please excuse me for that. The critical limb ischemia is important because it inevitably will lead to amputation if it is not treated. As surgeons, we have to relieve the patient of the rest pain, heal the ulcers. We have to keep in mind what revascularization attempts have been done before, what type of procedure we have to do, and not to forget, patient's overall ability to recover is very important in these cases. So according to the recent guidelines, how can we fit the surgical options in peripheral critical limb ischemia? For aortoiliac disease, there's no doubt that for A and B lesions, endovascular therapy remains the choice. Surgery will have some role in good risk task C lesions, but definitely for task D lesions, this is still the procedure of choice. Hardly anyone would argue that this sort of a lesion is best treated by the commonly performed aorto-bifemoral bypass surgery. This is just diagrammatic representation of how things can be done. In lesser risk patient, poor risk patients, or if the disease is less extensive with a relatively normal one side, then a lesser procedure of a femorofemoral bypass can be performed. This is just a diagrammatic representation of a cross-femoral bypass or a more ergonomically desirable iliofemoral bypass. This probably is an antique procedure of an iliac end arterectomy using a ring cutter. Some people still perform open end arterectomies with or without patchplasties. In poor risk patients, if the axillary artery is decent, then axillo-bifemoral bypass, or less desirably, biaxillo femoral bypasses can be performed. So this is a heavy slide, a busy slide, but it just shows the recent classification or change of classes as per the task guidelines. Again, for the femoropopliteal or infrainguinal disease, endovascular therapy is the choice for the smaller lesions. The limit has been extended. Type B lesions, occlusion up to 50 centimeters or 15 centimeters. Surgery, interventionists will contend about this, but remains the choice for task D lesions and good risk type C lesions. Saphenous vein remains the choice conduit, whether it is above knee or below knee, or even to or especially to the crural arteries. This is just a few examples of an above knee femoropopliteal bypass graft. This is a patient recently operated, 2 days post-operative, had no reconstructible arteries above the knee. This has been put in the upper anterior tibial artery, which was the only runoff, and the ulcers have started to dry up. And this is an example of a Belloni femoropopliteal bypass. As I said earlier, reverse long saphenous vein is probably the commonest conduit that we are using. Some surgeons like to use in situ long saphenous vein. If one is using prosthetic graft, it's always desirable to put an interposition of a vein, whether in the form of a venous patch or a vein cuff. That's a personal choice. If you are exhausted of the venous conduits, then a synthetic pre-made cuffed graft is available by the name of Distaflow, and it can be used in distal arteries. Sometimes we have to use sequential grafting. Intervening popliteal segment can be grafted as well, finally going to the distal crural arteries in the leg. Last but not the least, there are situations where amputation may be the best option, like in this 84-year-old lady who had a failed bypass done long time back. She presented 4 weeks after, 3 to 4 weeks after the failed bypass, and we had no choice but to amputate. So primary amputation is indicated if there is a significant necrosis in the weight-bearing areas, especially major loss of heel tissues, uncorrectable flexion contracture, and especially if you don't think the patient is going to live long, then why unnecessarily put the patient through prolonged bypass procedures or revascularization procedures. So in summary, role of surgery in the long term is probably going to be for long segment disease and salvage and redo procedures. In our setup, it will probably still last a little longer than the Western setup because of cost issues, unless the endovascular costs come down significantly. Future of vascular surgeons, I think people who do only open vascular surgery are an endangered species. They'll be carried by the endovascular specialists like this. Thank you very much.
Well, Dr. Mahajan, it was really a very nice presentation of the whole situation. But what you mentioned at last, that the role of vascular surgeon, definitely it has diminished, but there are cases when we think about the patient's future, and from case to case, there are cases where a good femorotibial bypass gives excellent long-term result, and that we wouldn't have been able to achieve by doing an endovascular intervention. And that is definitely, the decision has to be taken from case to case. And still I salute the dedicated vascular surgeons who have definitely saved the legs of some of my patients, which I couldn't have done by endovascular intervention.
Dr. Zahar, I couldn't agree more with you.
Doctor, you mentioned about the saphenous vein and the EPTFE and those kind of grafts. What about human umbilical vein? I mean, do you feel that's an alternative at all? Because I thought that had better results than the Dacron and the EPTFE grafts.
It is being used in limited places. I mean, the results are not significantly different, but reverse saphenous vein per se has a definite edge over the synthetic or the preserved grafts.
Any question from the audience, please? Well, certainly then, thank you very much, sir. But when we're talking of the role of the vascular surgeon, I think time is also coming for, we're going to have hybrid procedures, and they are well described. So probably the role of surgeons would be there in those kind of situation also. And it's probably the joint role which ultimately working in tandem and together, which will take this specialty forwards.
Yeah, hybrid
Thanks a lot.
will remain the future, yes. Thanks.